I'm Dr. Penninah Lutung. I'm the Bureau Chief for AIDS Healthcare Foundation for the Africa region. I'm here to share with you our experiences over the last 6 months in regards to ensure that HIV service delivery continues. I'm specifically going to be talking about our experiences regarding HIV screening, testing, and linkage to care during the COVID-19 era. A brief background to this regarding AHF's operations in Africa is that we work in 13 countries across the sub-Saharan Africa region, ranging from Sierra Leone in the far west to South Africa in the Southern African hemisphere. At the end of last year, we're taking care of over 670,000 patients in our collaboration with the various governments with whom we work in these 13 countries. We also performed over 2.4 million tests and overall found an average seropositivity of 3.8% and identified about 45,000 patients, just over 45,000 patients, and managed to link 77% of these patients into care. This year, between January and June, we've only performed 886,000 tests. That background is important because it's going to give us shed light on how much COVID has disrupted the service delivery regarding HIV and AIDS. That said, despite COVID and having to battle COVID, protecting the continuum of care was very essential to ensure that services continue to get delivered to people who need them and that HIV is not forgotten amidst the COVID epidemic. So in regard to HIV screening and testing, a bit of the brief background in this regard to share some of our testing strategies before COVID. They included a community aspect as well as a facility level aspect. With the community aspect, we're offering HIV testing services, specifically targeting high-risk populations, sex workers, truck drivers, men who have sex with men, fisher folk, young women and girls. These services were important. It was important for us to continue, to have these services because this high-risk population sometimes do not have time or access to health-level facilities. So we're taking the services to them to ensure that there's more convenience. On the community aspect also, our index testing had both a community and facility level, aspect strategy to it, because we're using some of the index patients we had and getting their consent to contact their partners, whether they were in the community, and basically taking the service to them to ensure that they can be able to access services conveniently and then being able to link them to the facility. At the facility level, we offered a combination of provider-initiated counseling and testing so that everyone who was going to a health facility to seek whatever type of service was offered an HIV test. And we've generally found that the acceptance rate for this has been very high. We also had walk-in clients who on a voluntary basis would not want to know their HIV status and walk into the facilities, and we're also able to offer them HIV testing services. However, because of COVID at the beginning of this year, most countries in Africa started reporting the first case. The first case was reported in February in Egypt. But by March, majority of the countries in the sub-Saharan region had started reporting cases. And so countries took on board lockdown measures, various lockdown measures, and this, in most cases, led to the suspension of community-level HIV testing to avert further infections, because typically community-level testing had large crowds gathering to receive an HIV service because it was taken to them at a point of convenience. The lockdown measures also had restrictions on transport access, especially public transport, and so people who wanted to attend HIV services at the facility level or just to attend general services within the facility levels had restrictions on transportation, and this further disrupted how much testing we would be able to offer to individuals at the facility level. That said, we quickly had to come up with options to ensure that the continuum of HIV care is not further disrupted. So we took on board a number of strategic interventions. The first one included enhancing facility level testing because health as an essential service continued to be open. And so the services were all expected to continue. And so we took the opportunity to enhance testing at the facility level. We enhanced the number of points at which we're offering testing, including outpatient departments, inpatient wards, TB wards, male and female wards, STI clinics, antenatal clinics, whatever departments were available depending on the health facility level, we ensured that we're offering HIV testing services. We also deployed a number of the community level testing staff to the facility level to ensure that the service points were adequately staffed and that we were not, were able to offer testing services, at a higher level within the facility. Many governments, the third intervention was to enhance HIV self-testing within the facility and at community level. And we did this because a number of countries have policies in place that, that allow for self-testing to be increased. And so our strategy was to increase the distribution of test kits, to especially priority groups. The key target was pregnant mothers at antenatal wards, at antenatal clinics. So we use them as points to access their partners. So by providing them with counseling and giving them the test kits to take to their partners in the community, we're able to ensure that the services are extended beyond just the pregnant mother at the facility level. We also amplified index testing and assisted partner notification because we already have a base of patients that we take care of. So these index patients, in most cases, will have a partner or partners that who are their sexual contacts. So based on their consent, we're able to also amplify assisted partner notification and testing, so that we're taking the services to their partners, whether they would agree to come to the facility for testing or allow some of our community level staff to approach them within their locations and offer the testing. Those options were made available to them. A couple of the community-based partners we work with also run drop-in centers, and these are simple rooms that ensure that their basic services provided. They will offer HIV testing, they'll offer HIV information, condoms, and most of these are located closer to the community, for instance, in market locations, so that these services also continued at a point of convenience for the patients. We also ensure that in some countries, the option was available to provide testing within the communities, and this was done by extending services to the community at a point when they were doing community level COVID testing. So they would bring along other services, especially this was common in some of the provinces in South Africa, where when COVID was being offered during the testing, community testing outreaches, HIV testing and other basic primary healthcare services were also offered. These we saw take place in some provinces in South Africa and in Sierra Leone. Lastly, as part of our strategic interventions, we ensured that community testing during the COVID times was still made available, keeping in mind the COVID guidelines that was in place by a number of governments. And so through these means, we're able to still offer HIV testing and screening and testing services to a number of communities. That said, I think it's important for us to see how much disruption we've had to HIV testing. And this graph basically compares testing outputs between January to June 2019 and 2020. During the period of January to June 2019, we were able to test over 1.2 million people. And yet in the same period for 2020, we have tested only over 880,000 patients. Most of the drop you can see, as per this graph, was between the period April to June. This was a time when most of the lockdowns were now in place, especially the stringent lockdowns in place. And so it reduced access, especially with transportation to the health facilities, but equally a number of the community level interventions were curtailed. So this has definitely, COVID has had an effect on how much we have been able to get done, because at this point in time, we should have had either the same or much more testing being done by the countries. But that said, the positivity has been, in terms of the yield from the testing outputs, the positivity has come down in 2020, but not as much. So we hope that, with further interventions, this will be able to pick up. But definitely in terms of how many people were able to reach, this was disrupted due to COVID. Secondly, to discuss the last aspect of this presentation is the aspect of linkage to care. This has been the most, not seems, but has been the most disrupted. In 2019, we were able to link 77% of our overall patients who tested positive into care. But at this same point in 2020, we've linked only 42% of those individuals. This requires that we have further strategic interventions to improve linkage to care. Despite having a number of new regulations in place that restrict access to care, despite some fears that patients may have regarding reaching health facilities, despite a number of other obstacles may be standing in the way. That said, what have we done to overcome these disruptions? One of the key ways we use to reach patients is using their mobile phones. Phone penetration in Africa has improved a lot over the years, and so majority of our patients will have a contact phone number, or they will have another individual through whom you can reach them if you need them. However, what we discovered was that only 25 to 40% of our patients in most of the countries were reachable over a phone line that they listed as their contact. Most patients will give us a phone line, but for various reasons, they may either change the phone line and not, inform us, or sometimes for stigma, they may block out certain calls that, they may expect. So we were not able to reach the majority of the patients using just, their mobile phones. So we had to devise other means that we would use to reach them. We engaged our community-based organization to follow up on the patients who had tested positive and had given us their consent to follow them up, to support and link them from the community level to the facility level. But that said, we were also able to take services to some of the locations through peer networks to drop off medications or to find a patient who needed to receive services if they tested positive. We also used locator information. Some patients may not have given us a valid phone number, but they gave us their physical address. So we used that locator information to be able to trace some of them. We've also used peer networks for the number of the peer groups that we reached, especially for the young people. It seemed to be the best way to reach young people and adolescents, to get to the facility, using their own networks of people that they know to reach out to them to get them to the facility. We also utilized some non-essential and some of our own essential staff to enhance calling patients and connect with patients generally to ensure that they came back into care, or that they were linked to a facility that was close to them. So what are some of the lessons we've learned in these 6 months? Stigma, we found that stigma still remains one of the biggest hurdles to scaling up certain interventions, especially index testing and assisted partner notification and linking patients to care. Patients will not give you a valid number or a valid locator information just because they do not want you to reach out to them because they have not yet had the opportunity to disclose. So supporting patients to disclose to their immediate loved ones so that those individuals can help them access care and stay in care is very critical. Correct locator and phone information is critical because it helps to increase access to care. Once you can reach the patient, you can be able to guide them and support them to stay linked to care. Offering alternative, convenient, and flexible means of testing and linkage to care is key, especially during these times because disruption caused by COVID restrictions, definitely for some individuals, they will have no way out. They cannot reach a health facility because they do not have transportation there. So being able to take the service to them, use peer networks is very, very helpful. In getting them linked to care, or even offering them an HIV screening test. Intensifying HIV screening at the facility level was key in helping us get to the 880,000 individuals we tested, And so just offering the service in a more widespread manner within the facility, was very key to that. And then using data, epidemiological data, to determine who gets tested and prioritizing that above, a lower risk individual is also key, because it has helped us to ensure that we can locate resources, the testing resources, the staff resources, the interventions that can help us identify those who are most at risk first. And then the peer networks, as I mentioned, is very key, because they will reach individuals that you as a typical health worker may not be able to reach, but then they will speak the right lingo, they are trusted by their peers. And so using those peers helps them to get tested, but also to link and help them retain them once they access care. So those are some of the lessons we've learned and shared with you our experiences. I'm certain that by the end of this epidemic, we will have learned a lot more, and that will help us to further determine and devise means of ensuring that the continuum of HIV care is not further disrupted, and that we can survive, and ensure the HIV as a pandemic is not forgotten despite COVID being in our midst. I would like to acknowledge a number of colleagues who have helped with this presentation, as listed on this, listed here, and specifically IAPAC for the opportunity to share our experiences. Thank you.